Ghani. I'm a first-year resident at the University of Arizona College of Medicine, Phoenix, internal medicine program. My attending is Dr. Allison Biget. We're affiliated with Banner University Medical Center. The title of my case presentation is Rare Presentation of Diffuse Large B-cell Lymphoma, Lactic Acidosis, and Transaminitis. I want to start off with the case. So we have a 60-year-old Hispanic male with a history of diabetes who is on stigoliptin and metformin, glyburide, and metformin. He initially presented to his PCP with a 1-month history of generalized fatigue, weakness, and a 20-pound unintentional weight loss. He was admitted, and over the next 8 hospital days, he had worsening lactic acidosis, uptrending PT-INR, and his imaging was diffusely negative. He also had increasing bilirubin that was concerning for liver failure. He was started on renal replacement therapy on hospital day 5, and our presumed diagnosis was metformin-associated lactic acidosis. He had an ultrasound-guided liver biopsy on day 6 for an urgent liver transplant. He started having respiratory distress on day 7. He was intubated, and his lactic acid continued to rise despite renal replacement therapy, and in addition to antibiotic therapy with doxycycline, ceftriaxone, and Levaquin. He did not have cholecystitis, but there was gallstones that were seen on imaging, and we prophylactically treated him with antibiotics. On day 8 of his hospital stay, his family decided to move towards comfort care, and after the patient expired, his liver biopsy results finalized as diffuse large B-cell lymphoma, activated B-cell type. His lab results are presented below. As we can see is that he had transaminitis seen on day 1. His platelets were low, which are of concern, and he had a lactic acidosis of 6.5. On day 1, when he presented to the hospital, he had no symptoms. His only symptoms were weakness and generalized fatigue. We worked him up from a liver standpoint completely. We did alpha-1 antitrypsin, ceruloplasmin, anti-nuclear antibodies, anti-mitochondrial antibodies, and they were all within normal limits, as you can see. He didn't have hemochromatosis. We also drew metformin levels on day 1, however, they didn't result until day 5 or 6, and they were completely normal. We also did all the hepatitis panels, viral hepatitis panel, and they were all diffusely negative for acute hepatitis. As you can see with our lab results here, with the lactic acidosis from day 1 to day 8 when he expired, he had continually increasing lactic acidosis. His ABGs, he was acidotic on day 2, and he had an anion gap on day 2, also had an anion gap day 5 and day 8. His imaging, he had pretty much a full body scan. He had a CT of the abdomen, the chest, abdomen, and pelvis, which just showed some fatty infiltration of the liver and some gallstones. He had an MRI of his abdomen, which just showed moderate hepatomegaly, 2-centimeter gallstone, no biliary dilatation, and some bilateral simple cysts, minimal peritoneal fluid, as you can see. I have the images that I thought would present negative pathology. This is straight from his CT scan down here and from the MRI above. The liver pathology that was taken on day 6, as you can see, showed diffuse large B-cell lymphoma, the activated B-cell subtype. And it also showed, as part of the biopsy, just some background liver with congestion and sinusoidal dilation. So what I want to talk about is the importance of having a broad differential when it comes to lactic acidosis. As we know, the main type of lactic acidosis that we care about, especially in the ICU setting, is marked by tissue hypoperfusion. The other type B lactic acidosis, is related to causes other than tissue hypoxia, and that's called type B. We're very familiar with type A. It's in shock. We see that in carbon monoxide poisoning or severe anemia, basically less oxygen delivered to organs. However, the type B lactic acidosis can be related to drugs such as metformin, beta agonists, and nucleoside reverse transcriptase inhibitors. It could also be related to malignancy, such as this case, thiamine deficiency, alcoholism, or seizures. When thinking through this case and understanding how we should treat him, given his negative imaging, and the fact that he uses metformin, although his metformin levels were 0, we really had nothing else to go by. He didn't have any signs of mass. He didn't have any lymphadenopathy. His imaging was completely clear. So our only presumptive diagnosis was that he had metformin-associated lactic acidosis. In the literature, it says for someone to be diagnosed with metformin-associated lactic acidosis, you have to meet 5 criteria. One is that they have to have a history of metformin administration, which our patient was using his metformin correctly. He was actually evaluated by psychiatry, and they confirmed that, 1, he's not an alcoholic. He has a few beers socially per week, 2 to 3 beers per week socially, and he takes his metformin as prescribed. So it wasn't like he was taking his metformin more than he was supposed to. However, you can still get mala with metformin consumption regularly. 2, for mala, you have to have an elevated lactic level greater than 15 millimolars per liter. In our patient, he only reached those levels on day 7 and day 8. You also have to have a very low serum bicarbonate level. In our patient, his serum bicarbonate levels weren't below 10 at any given point in his stay. 5, you also have to have renal insufficiency, defined as creatinine above 2.0, which our patient had a normal creatinine below 2. So he did not meet all 5 criteria. Given the criteria for mala, he only met 3 of them. And again, given his negative laboratory workup for viral hepatitis, autoimmune hepatitis, our presumptive diagnosis was mala, and we had no answers for his increasing lactic acidosis, and that was our reasoning for putting him on renal replacement therapy. We did think of the potential of him having malignancy. However, what pushed us towards the diagnosis of mala was the fact that his imaging was completely negative. And given that we're a big liver center, our idea was that he's quickly going into complete liver failure, and our goal was to get him a transplant quickly. That is part of the reason why we also had a psychiatric workup, which defined him as low risk for liver transplantation. And it was only after the liver biopsy results came back was that we found out that he actually had diffuse large B-cell lymphoma. The important teaching point, I think, from this case was that although we know how to treat type A lactobacillosis really well, I think we should always have a broad differential, especially when it comes to other causes of lactic acidosis, especially when it comes to malignancies. An increase in lactic acidosis in malignancies appears to be a marker of poor prognosis, and as we saw how quickly this patient went downhill, that is evidence for that. And there is 3 theories as to why lactic acidosis and malignancies occur. One of this is that there is decreased hepatic clearance of lactic acidosis, and there might be a thiamine deficiency, which our patient did not have. Or the other theory of why there is so much lactic acid production is because the actual malignant cells undergo anaerobic glycolysis, which causes an increase in lactic. And again, thiamine deficiency is an important cofactor in the pyruvate dehydrogenase complex, and a deficiency in thiamine would lead to more anaerobic metabolism of this pyruvate. So overall, I think this case emphasized that we need to keep, again, a broad differential when it comes to elevated lactic acidosis. We should consider hematological malignancies such as diffuse large B-cell lymphoma, as it could be one of the ways it presents itself. And since it's a rapidly growing cancer, it needs to be diagnosed quickly, and patients need to be initiated on chemotherapy. There is definitely more data that needs to be created, that needs to be sought so that we can create treatment protocols. But the ongoing general consensus is that we need to quickly diagnose these patients who have diffuse large B-cell lymphoma and presenting themselves with just lactic acidosis. We need to treat the underlying malignancy and make sure that they're not thiamine deficient, because it could be critical for them and their prognosis. Thank you so much, and I hope you guys have a great day.